So welcome everybody. My name is Alia and I am with the research and advocacy team here at Muscular Dystrophy Canada. I just wanted to welcome everyone who stayed here and stuck with us. Welcome you to our webinar on caregiver resilience. This is part of our Let's Talk NMD webinar series, and we are happy to offer today's webinar in both official languages. You can use the globe icon to access the language of your choice. It's in English and French. Oh, let me just check the chat to see if there were any questions. I know. Okay, great. And so we are very excited to have Kathy Netten here. And just, I want to double check with Marie-Hélène if everything is okay.
Oui, en fait, je suis pas capable d'enregistrer, Alia, mais sinon, je pense que tout va bien.
OK. Est-ce que c'est correct? Je ne sais pas pourquoi ça ne fonctionne pas.
Ah oui, ça fonctionne maintenant.
One of those wonky days. I haven't even touched anything, so it is now working. OK, excellent. Merci beaucoup, Marie-Hélène, pour votre patience. Okay, I think Marie-Hélène is good to go now. Okay, great. So Kathy Netten has been a healthcare provider in the Toronto area for over 25 years. She's been in Toronto for over 25 years as a social worker. She started first with the University Health Network and then joined the city's world-renowned Hospital for Sick Children in 1996. Kathy has worked in a variety of roles and departments at Sick Kids, and she's currently a social worker in the complex care program. In her position as a co-supervisor of family therapy treatment seminar and providing strength-based family therapy while mentoring social work students in this treatment modality. So Kathy, I really want to welcome you, and thanks again for being patient, and thank you to everyone. And I'm happy to help you share screen.
Good afternoon, everyone. Thank you so much for staying online and waiting. And I am very apologetic for our technical difficulties. This is a talk that was created with one of our complex care parents. And the idea of grit, resiliency, and recovery is that when parents are caregivers and they have been profoundly impacted by the care that they provide each and every day and what they see their child go through, many of our parents have trauma. And the idea of grit, resiliency, and recovery is that even when individuals have difficult times that are profoundly impactful, there is hope and there is opportunity for recovery and new meaning. So this is a very important talk and is very sort of close to my heart. So Natasha could not be here today, but we will be talking about some of the issues that she introduced. So in this session today, we're going to talk about why is trauma so common for caregivers of children with medical complexity? How does trauma impact caregivers of children with medical complexity? And what can we do? Just a quick definition, children with medical complexity are children that are dependent upon technology for survival. That may be a feeding tube, that may be suctioning for deep suctioning, it might be a tracheostomy or a ventilator, non-invasive ventilation. These are the children who require intensive medical support, often developmental supports as well. And these are the kids that are usually connected in school settings, hospital settings, rehabilitation settings, and they likely have services at home. So it fits very nicely within the neuromuscular community. Next slide, please. So parents of children with medical complexity have an unbelievable, inordinate amount that they are juggling each and every day. They are typically sleep deprived because they are providing care partway through the night or responding to their child overnight. They witness acute life-threatening events on a regular basis. They are caring for their own child, which is very different than healthcare providers that are caring for people that are not related to them. In fact, in healthcare, we're often told that we're not allowed to care for our own child, and yet we expect parents to do this and do very intrusive, difficult interventions with their own child. There's many system stressors, paperwork, navigating a system, finding the right people. There's things like doing your groceries, doing laundry, ordering supplies. Often families will say that their friends or other people are not going to understand what their experience is like because it's quite different than what other people are doing in terms of parenting. There's a lot of uncertainty, and the chance to sort of maintain yourself and sort of keep up social engagements, work opportunities, recreational opportunities, any of the self-care things that you did before caring for this child, chances are you're not able to maintain it. And of course, often so many of our families have huge distances to travel, so they're very far from their home supports. Next slide, please. Okay. Systems are not really set up for families. They're more set up for the healthcare team or rehabilitation team. They're not really child and family centered. Often families will come to the hospital for appointments. They have long waits in rooms that are not really set up for children that might be in wheelchairs or who have visual or hearing differences. And it's really tricky to kind of navigate those situations. Dr. A.L. Cohen published a paper many years ago that showed that as time goes on, family income actually declines because the needs of the child increase. Profound stress, toxic stress, living constantly in sort of survival mode, vicarious traumatization where you're witnessing code blues or hearing code blues and code whites. And then there's many, many hospitalizations where it's really difficult to kind of get your feet under you and sort of find a nice baseline. Next slide, please. So the expectation that we can be immersed in suffering and loss daily and be untouched by it is as unrealistic as expecting to be able to walk through water without getting wet. So this idea is that we are getting wet. This is a very impactful experience. Next slide, please. One of our complex care parents created this care map, which outlines sort of the large circles are the hospital, the community support, school, and then nursing agencies. And this is what a parent has to navigate on any given day. They have to get medications from the pharmacy. They have to schedule healthcare providers to come into the home. They have many healthcare appointments that they have to do. They have rehab appointments, seating clinic for the wheelchair. They have to make sure that their healthcare staff in the home is actually trained. They have to deal with social work, OT, PT, etc., etc. And this is, the mom joked that after creating this incredibly sort of overwhelming visual display of what they deal with, they realized that they actually forgot a number of providers at school. Next slide, please. Okay, so when you think about how much parents are managing, then you add the stress of hospitalization on it. Where do parents sleep? Where do they eat, shower? Do they have time to be alone? And how are kids supported? Often what we find is that at home, children may have one-to-one, and then they come into hospital when they're acutely unwell, and their staffing actually goes up to 2-to-1 or even 3-to-1. What happens to siblings when you're in the hospital, and who can visit? This has been very important during the pandemic, in that often hospitals have had a policy where only one provider or one parent has been in hospital, and during the most stressful times when parents have been most terrified, they've been sort of separated from their partner or their friends. Next slide, please. So I just pulled together sort of a compilation of stories. None of these are actual true situations, but they absolutely come from true like experiences that many families have had. So if we think about Jessica, Jessica is a child and has a mom, and this child has had 43 visits to the surgical waiting room for really intensive procedures. They have been in hospital for over 400 days, far, far from home, and this child has had multiple cardiac arrests. If we think about Liam, Liam is a child who also has medical complexity, and this parent has heard the oximeter alarming when the parent is in the shower. Parent has jumped out of the shower, raced to Liam, and realized that the oximeter was actually returned a year ago and that the child no longer has one. Aaliyah is a school-age child, and this mom, when they are in hospital with Aaliyah and they hear a code blue called overhead, they will faint in the patient room. Omar is a teenager, and his parent feels very, very angry when care providers don't return phone calls, and staff feel that Omar's dad is aggressive. What is it that these parents all have in common? Next slide, please. They share trauma, and trauma is can be defined through the American Psychiatric Association as an emotional response to a terrible event. It could also be thought of as an overwhelming event experienced without support. So when you are alone and you experience this overwhelming thing, a simple and effective definition would be an emotional shock. Next slide, please. So complex care parents, as you can probably tell by all of the slides we've already covered, are hugely at risk for post-traumatic stress disorder. The amount that they carry, the sleeplessness, the exposure to acute life-threatening episodes puts complex care parents at very high risk for post-traumatic stress disorder. This is a definition from the American Psychiatric Association, and I think what is really significant for me is that if you look at this, it is the idea of either experiencing it yourself or witnessing somebody go through this. And when you think about the relationship between a parent and their child, you cannot think of, I think, anything more terrifying than thinking that your own child might be at risk of dying. Next slide, please. Okay, what we also know about trauma is that there's something called the building block effect. If you have maybe one event or two events, chances are low that you're going to have trauma, but as the blocks stack, the likelihood of having trauma is much higher, or post-traumatic stress disorder. And what we know is that there are changes in the brain. We move from what we call our prefrontal cortex to our limbic system, sort of our downstairs brain. And that often what happens is that hot memories, or memories where we have emotion and body experiences that are separate from our prefrontal cortex, or these hot memories grow over time. And then we start to sort of be triggered by things that weren't even connected to the traumatic event when it first happened. Because what fires together wires together. So these memories become linked over time. Next slide, please. So post-traumatic stress disorder can be thought of as having sort of these 4 symptom clusters. One is re-experiencing. This is sort of the nightmares, the painful emotions that seem to be disconnected, or these implicit memories, fear and anger without sort of apparent cause. Avoidance, staying really busy and preoccupied so that you don't have those feelings. Isolating yourself, or sometimes using alcohol or drugs. These negative cognitions or mood alterations, there may be feelings that you can't depend on anyone, you can't trust anyone, you might feel worthless or have suicidal ideation. And then there's sort of this hyper arousal where you just never can feel relaxed. your muscles are tight, you're breathing fast, your heart is beating, you're constantly on and never get to turn off. Next slide, please. Okay, this is something called the window of tolerance. And in the yellow, you see sort of our window of tolerance. Most of us are born with sort of this range where we're in our prefrontal cortex. This is where we feel calm. We are able to make our best decisions. We are alert, we're connected, information comes in and goes out. And we sort of move through our emotions within this window and we're not overwhelmed. What happens though is that if we have too much coming at us, we can go above our window and hit this hyper aroused state. This is where we leave our prefrontal cortex and we go to that downstairs brain I was talking about earlier. When we're hyper aroused, we're actually in our survival mode. We are in fight, flight, or freeze. We are super dysregulated. We can also go below our window. And what happens is we shut down, we kind of freeze, we numb out. And to return to that optimal window, we need safety. And what we know is that when we're tired, our window shrinks. When we're hungry, our window shrinks. And that many people who have trauma, their window is very small. So emotions that before they were able to manage now are overwhelming. Next slide, please. Okay, this is in the Journal of Psychology, and this is a graph. If you imagine all mammals have this sort of defensive reaction, and if you can sort of picture maybe a gazelle, in Africa on the plains, the gazelle is eating, it sees a movement out of the corner of its eye, and what happens is it immediately freezes. It's this sort of immobility, which is like an orienting response. Was that really a lion I just saw? Oh yeah, that was a lion. Then what happens is the gazelle leaves sort of their prefrontal cortex, or actually gets into this survival mode, and you have flight, so it tries to run away, or you have fight. If the lion gets it, it will sort of kick out. If the lion, though, has the gazelle and the gazelle can't get away, it's at the peak of this curve and it's at fright. And what happens is that all of the energy of the gazelle is going into finding a way to escape, to get out. It becomes very, very still. And if it can escape, it will, and it will return to its baseline. If it can't escape, it goes down this curve. And instead of having a sympathetic nervous response system where your heart is beating faster, your breathing is more rapid, you literally start to deactivate or shut down. You have a parasympathetic response. And if that gazelle cannot get away, it will actually faint. This happens in people as well. And it's important to know that is someone on sort of the sympathetic trajectory or the parasympathetic trajectory? Are they dissociating? Next slide, please. So if you think about sort of these two sides of the curve we just described, you can have people who are predominantly in the sympathetic nervous response when they have post-traumatic stress disorder. There's this vigilance, resistance, defiance, aggression, or people tend to be on the parasympathetic side where they dissociate. So they avoid, there's compliance, dissociation, and then they collapse. Next slide, please. Why I put this slide up is that if you think about it in terms of columns, down and across, what we know is that people, when they first begin to experience stress, again, they're in their prefrontal cortex and they're very calm. But what happens is that very quickly people go to their limbic system and actually potentially to their brain stem. And the brain stem, there's absolute terror. And when people begin, they can think in terms of days, weeks, they can plan. But by the time you get to your brain stem, there is no time. It feels immediate and you cannot plan. And it's really important to think about that if you have post-traumatic stress disorder in terms of regulating, and healthcare workers need to be very aware of this. This is where we can help families. We can sort of help recognize when this cascade is occurring and bring people back, hopefully, to calm. Next slide. So this is the blog from Natasha Barry, the parent who previously presented some of this material with me. I am going to read it, but I want people to know that even when Natasha posted this blog, she did write possible trigger warning, PTSD open discussion. And I'm going to suggest that you just do whatever you need to do to care for yourself, okay? So here is Natasha's experience. For those of you that have had to stay at Sick Kids, CHIA, or any other hospital, testing, investigating, preventing, treating, recovering, or losing a child, I see you. I've been to some of those places myself, and being a parent of a child with complex needs, I will be there again soon enough, I am sure. I watched this video I shared because I love and usually feel so validated by the Sick Kids commercials. However, this time was different. I have been diagnosed with post-traumatic stress disorder as a result of everything we have been through with our daughter's medical complexity, and how many times I thought I was losing her before my very eyes. As it turns out, tonight was the perfect night to be completely triggered by the video instead. If you or anyone you know experiences triggers and has flashbacks, please do not take them lightly. They are absolutely awful. The video shows the halls, rooms, doctors, nurses, sick children, and their parents, caregivers. It shows the bright overhead lights, has the hospital background soundtrack of machine beeps and buzzes, and in an instant, I'm transported back. My body is paralyzed in fear and uncertainty. I sit completely still, and I am then flooded with it all again, without the ability to snap myself out of it and just think of something else. First, I smell the smells of the hospital: Tim Hortons, food court, EEG glue, the floor cleaner the housekeeping staff use, the arrowroot cookies I would take from the kitchenette when I was too nervous or busy to eat an actual meal, just to hold me over until the next package of cookies. Next, I see flashes of still pictures in my mind. There I am on 7D when we didn't know what was happening with our child and she got a nasal feeding tube inserted. Boom, I'm in the elevators when a child I don't know collapses, and I see the fear I feel as a parent from my child written all over the faces of the parents of the other child. Boom, code red, fire, boom. My daughter is screaming in terror as they hook her up to another EEG. Boom. 5 words that would change my life forever: pyruvate dehydrogenase complex deficiency disorder. Boom. There I am asking the doctors, am I going to lose her? And the doctors replying, yes. Boom. I'm sleeping in a playroom on a cot with mothers I don't know because my husband is in the room with our daughter that night. Boom. Code blue, 7D. I repeat, code blue. Boom. Wait, we're on 7D. I'm not with my daughter. Everyone is rushing. Let me get to my daughter. Ma'am, go back to your room, please. Is it my daughter? Tell me it isn't my daughter. Boom. I see another child being rushed away. Boom. Relief, the child wasn't mine. This time, boom. Heartache for the parents walking behind their child. Tears for myself. Tears for my family. Tears for the medical and hospital staff that see these scenarios every day. Tears from my future self when it may be our turn to have a code blue called for us. So many tears. Boom. I'm in my living room crying in real time. My daughters are safe and sleeping soundly. I'm comfy and cozy, so why do I feel like I'm in a crisis? I'm crying, hot, heart is racing, I'm breathing fast and instantly feel sick to my stomach. This, my friends, is the power of trauma. The stuff that we are exposed to for our own children is really hard, but the things that we witness when we're in the hospital caring for our children is also more than anyone should have to go through. I'm trained in mental health. I am trauma informed. I see a social worker, psychologist, psychiatrist, and I'm actively working on processing all of this, and I was still triggered. So please, if your mental health has declined since being a caregiver, it's understandable, but it is often too much for us to deal with on our own. If you feel like you need help, reach out to a formal professional to work on whatever is needed so that you can continue to be the best caregiver for your loved ones as possible. Next slide, please. So just maybe take a moment and take some breaths. It's still, it's so powerful whenever I read it. And it's just such a clear depiction of what families experience when they are in the hospital setting with their medically fragile child. So as we think about this, what can be done? So these are sort of my ideas. Trauma-informed care. This is where we create safety, choice, collaboration, trustworthiness, and empowerment, not only for the medical institution, but also for the people that we are caring for. Trauma-informed care is a way of switching from what's wrong with you to what happened to you. It's about assuming that most people have experienced trauma, which is actually borne by the literature. There's adverse child events, there's research that tracked people over time, and what we know is that when people have experienced multiple traumatic events before the age of 18, they are more likely to have post-traumatic stress disorder, and that the rates of trauma are very, very high. So switching to trauma-informed care is an important first step. Creating child and family-centered care that is really child and family-centered. We remove barriers so parents and children and siblings can be together during clinic visits and hospitalizations. We focus on relationship rather than process. We're curious, what's happening with this parent? The number of parents that have told me that after their child has experienced a code blue or a difficult procedure, almost no healthcare staff have asked them, how are you? How are you experiencing this? Embrace compassion, especially self-compassion. We've learned that compassion is actually protective, and that self-compassion can actually protect us from burnout, and it can also help us remain connected. We need to create meaningful mental health treatment opportunities for parents, siblings, and children living with medical complexity, because not only are parents impacted, but the patients, their own children are impacted, as well as siblings. And ask parents how they're doing. In a journal article by Dr. Rosberg, Orkin, Cohen et al., they have suggested that parents of children with medical complexities see their child's pediatrician more frequently than they see their own healthcare provider, and that pediatricians should be cued to be asking parents, how are you? When was the last time you had primary care? Is there something that you need? Next slide, please. This is a new paper, Caring for the Caregiver, an integrated step care model for caregivers of children with medical complexity. And it is going to be published in the academic pediatrics. It hasn't been published yet. This is a new model of mental health support that we are exploring here at Sick Kids. This is a model in which the nurse practitioners, who are sort of key workers in our program, and have sort of the most contact with parents, sort of recognize when parents are not themselves, when parents are maybe more stressed or overwhelmed than they have been in the past. And they will mention to the parent, would you like to see one of our social workers? Social work will then meet with the parent, will do an assessment, will offer psychotherapy, and we're really, truly providing psychotherapy. Not just coping skills, not just how to manage, but literally therapy around how to, find a life of meaning and purpose, and maybe to work through trauma that happened even before this child was born. If the parent has need of a diagnosis or potentially medication, we have a psychiatrist that we can refer to at Women's College Hospital, and the psychiatrist will see the parent and then refer back to us or refer out to community supports. We are currently seeing how parents are appreciating this model, and there may be more in the future. Next slide, please. So what parents, when I was creating this talk, I went to many of our complex care parents and said, you know, what do healthcare workers really need to know? And I spoke with a number of parents, and this is the feedback that they had for healthcare professional. Parents of children with medical complexity are not paid healthcare workers. These parents did not choose medicine as a profession. They are not doing this by choice. They are doing it because of necessity. And they are doing it to their own children. Most of these families, or many of these families, are living in extreme circumstances. Trauma is pervasive. Parents never get a day off. They never get a rest, a chance to recharge, or they get to kind of step away for a prolonged period. Healthcare workers, in contrast, they take breaks, they have lunch, they get paid, and they go home. Parents of children with medical complexity, they do not leave. Even when they are away for a few moments, they don't stop thinking about their child with medical complexity. Supporting your own child in a life-threatening event takes a toll, and living in the hospital is merciless. Next slide, please. So I spoke with one of the parents, and she gave me this quote, which I think is probably a good place to sort of stop. What to cover about trauma? I think that for me, even when I think I'm okay and on a good day, all it takes is one small trigger to throw me back into the deepest grief. I was fine, productive, calm. And then I saw something on social media that literally had me curled up in bed crying. But now, 7 years in, I know that's normal, and I will be okay if I just let myself feel it and get over it. I think what's important for me is that even when parents have grit, resiliency, and recovery, when they work through the trauma and create new experiences and meaning and growth, even then, it is still normal to be triggered. They just become more familiar with how to navigate it. There is no return to sort of before trauma and what life was like. So that is my slides. I don't know if there's the ability to have questions, but that's sort of the end of my formal presentation.
Thank you so much, Kathy. If anyone has any questions, would you like to put it in the chat and address it to Kathy? And sorry, my apologies, I should have mentioned that earlier on. Are there any questions for Kathy today? I know we're at the 5 o'clock mark. Feel free to post. Oh, okay, cannot post it. Okay, so if you have any questions, perhaps you can send them. Oh, Q&A. So we have a question here. It says, do you find the experiences that are unique to neuromuscular disorders?
So I think that the overlap for neuromuscular disorders and what I've just presented is very similar. I do think, though, that for families that are dealing with a degenerative neuromuscular disorder, there is an added piece, and that is the child has a level of functioning that they lose over time. So not only do you have trauma, you have grief, and there is something profoundly, I don't know what word to use, but there's something that is deeply, powerfully painful about watching your child lose skills over time and having to think about potentially dying from this disease. it's one thing to be born sort of with a baseline that you live with forever, but to lose skills, I personally have seen, is profoundly painful. And I think for me, that is the one piece that stands out for neuromuscular diseases, or maybe like certain metabolic diseases, that's different than something that's static.
Great. Any other questions? Feel free to post it in the Q&A.
One thing I will just add is that in Ontario, and I know that this is across Canada, but in Ontario, we do have something called Complex Care Kids Ontario, and we are working to create sort of guidelines for every family that's connected to a complex care program. And some of the physicians in our program have rounds across the country with fellows who work in this field. And we're hoping to kind of get the word out that in addition to the excellent medical expertise, the rehab expertise, we really need this mental health expertise to support children and families.
Wonderful. Thank you so much. I know we've gone over the 5 o'clock mark, and Kathy, thank you again so much for sharing your expertise with us today. I'm just going to share a screen very quickly. Also just wanted to, if anyone does have any questions, feel free to email us at research@muscle.ca. We also want to thank Roche for sponsoring this educational initiative like today's webinar. And we also want to acknowledge that the content of this webinar was done and created independently. So again, feel free to email us with any questions you might have. And we hope that you do join us for our next webinar on September 7th on mental health and youth. Kathy, thank you, thank you, thank you. And everyone, thank you so much for staying with us today. All the best to everyone.
Bye, everybody.
Take care.